Good evening. My name is Shreyas Jaikumar, and I'm part of teams 3 and 4. And my fellow teammates are Akshay Rajkumar, Siddharth Satish Kumar, Hobo Yang, Yukun Lee, and E. Rohit Reddy. And the topic that we are working on is in-network computing for real-time health. So, without any further ado, let's get started. And I'm going to give like a high-level overview, like pertaining to the introduction, the core problem, the solution, and why it's revolutionary, and why we have decided to proceed with this particular topic. So, so right now, somewhere here, both in America and in, like, to be honest, like in many parts of the world, an elderly person is wearing a small device on their chest, a heart monitor and a Holter monitor. Now, that little gadget is supposed to protect them. But the terrifying truth is that, like, when the heart starts doing something dangerous, that device sends the data all the way to a distant server in the cloud, uh, waits for a response, and then fires an alert. And that entire, A to Z round trip can take seconds. Now, seconds doesn't seem like a lot of time, but in case of a life-threatening cardiac event or an arrhythmia, it can mean the difference between life and death. And moreover, the battery drains so fast that the device needs constant charging, and the patient's private health data travels across the internet where it could be breached, and the AI running inside that particular device is completely generic. Um, because like it's good in general extrapolation, but per body, per your history, and like to your specific condition, it doesn't know that, right? So yeah, so that's kind of the broken part. And the solution as to why it's revolutionary is, as I stated earlier, our my team is building. We are all building an in-network computing for real-time multi-sensor health analytics. And the core idea is simple but powerful. Like, instead of sending the health data to the cloud and waiting for it, we kind of process it on an edge-based manner, like in the device itself. And our system intercepts health data on the wire before it ever touches a server, and runs a personalized AI model tailored to your specific medical profile in orders of milliseconds. There, as I said, there's no cloud dependency, there's no dangerous delays, there's no privacy risk, and etc. Like, this isn't kind of incremental improvement, it's a completely new architecture built on custom hardware acceleration. And um, uh, and this is sitting at somewhere at the intersection of an $80 billion market that is hungry for exactly this kind of a breakthrough. Now, on to the next topics. My teammates will take on from that. Thank you.
Hi, I'm Siddharth Satish Kumar. I'll be taking over the business and market opportunity for our model. So, in terms of business opportunity for our model, it's pretty high because it's pretty unique technology. Uh, yeah. So, should I just? I'll just present. I think it's kind of delays are there. So,
What?
hi, I'm Siddharth Satish Kumar. I'll be going over the business and market opportunity for our model. So, our model is pretty unique, and in the global landscape, it's pretty unique, and there's a huge market opportunity for that. In the current market, the opportunity for using a AI-based diagnostic software in healthcare is around 8.75 billion market cap is there, and the expected evaluation for our model in a normal AI sense is going to be around $4.5 billion, and there's a huge market for it in terms of number of patients required for around 40 million, and in the growing age of time, it's going to be increasing more with how the lifestyles are changing. So overall, around a large period of time, there's going to be a growing market for it with high amount of investment to be expected in the market for our model. The compound annual growth rate for us is around 9.5%. The compound annual growth is the measure for an annual based total growth for a product, and especially for an remote patient monitoring system with AI Edge AI, it's going to be very high, set a new standard for this, and it's going to double over every 2 years. So main market drivers for this is going to be the rising demand for continuous and non-invasive cardiac monitoring post-COVID, FDA and CMS reimbursement expansion for remote patient monitoring, growth of AI integrated diagnostics replacing periodic clinical reviews, and privacy regulation pushing data on edge, device trials, and cloud. So the competitive landscape for us is around these major companies, around three major companies: iRhythm by Zio, AliveCore by Cardia, and Heartbeam. So each of them have different models around this. It's not mostly all of them are not personalized. Some of them are on edge, but they have poor battery life, and the cost is pretty high to moderate. Compared to that, our product is having a better battery life. It's on the edge, and the cost is pretty low for a model, and it's also very personalized, integrated system. So for example, in iRhythm, it's cloud-based model, and Alive Core and is also an edge hybrid, which is not completely cloud, but also like needs a manual intervention for not to operate. While Heartbeam is fully cloud-centric model for three ECG cardiography waveforms and also high diagnostic accuracy, but fully cloud dependent, which is not ideal for our landscape for the use case for us. So our solution being very on the edge is pretty better for our model compared to these three models. And also a lot of these, as I said in earlier slides, they have a couple of strengths and also a couple of gaps, which is what we are trying to improvise with our model to keep the strength of the above and also like to fill the gaps in the other ones with a lower cost also. And our cost is kind of low for our model is pretty low, and which I'll go in the next few slides. So based upon these, our model, what we're planning on building is something which transmit data wirelessly to the smart network node, and the data will be interpreted on the edge by the cloud, and the AI model runs instantly for each patient's medical history, and within few milliseconds, nanoseconds, you will get like real-time alerts for the caregivers to notified for any sort of issues are there. This extends the battery life dramatically because the sensors only transmit and never compute, which is mostly case in other models because due to which they are having a lower battery life. Uh, this is because of our edge AI, which can interpret the data immediately without like need require for sensors to like transmit to modify the data for transmission. So that's how our model will go from sensor layer and then to like in network computation and then from AI interface and then alerting the caregiver for any issues are there. No cloud, no delay, and no compromise on the product. A core novelty is mainly around a personalized and conference-based edge AI. So it's a very patient-specific AI customization. So if any patient has some other sort of issues like AFib or bradycardia on their uh, case file history, then we can personalize our AI for their utilization instead of like keeping a generalized system, and which is pretty useful with how the patients are interacting. And on-device AI accelerator and custom CPU. So this is ours as an on-device AI accelerator with custom GPU, which is going to increase the speed and it's going to be very highly power efficient AI on-device interface. And there's going to be 90% data savings because of edge computation and no reliance on cloud for our model, which is again coming over to the next point is conference-based hybrid decision system. This is going to be on the edge, so it's going to have a high speed, accuracy, and safety intelligence. And there's no requirement for pushing data to cloud, which is kind of crucial for, especially for medical data. That is not required, and it's also going to reduce the latency very low, and escalation for deeper analysis and medical safety net. So other six technical novelties are the six pillars of innovation we are introducing in network packet inspection, RTL optimized custom math units, patient-specific adaptive weights, selective classifier execution, PJ to ASIC scalable architecture, and multi-sensor fusion on edge. coming over to the unit economics, so which this in this I'll deep dive into the cost of the module we are gonna do. So for production cost for our models from concept to deployment will be around ASIC development, packaging and testing, hardware product development, certifications and compliance, manufacturing, and shipping and miscellaneous costs. So one of the main thing for us is going to be on ASIC development and packaging costs. So for us right now, our ASIC is pretty much done. So our main cost for that will be around the EDA tools, which are not again not there for us and negligible for us at prototype level. We have to do multiple verifications though, which will cost us like which are going to be one-time cost, and then it's going to be multi-project wafers. It's going to be a more cheaper approach with using shared silicon. So for that, the cost will be around $3,000 on the lower end for multiple chips. And then the full wafer fabrication, if volume production is required, will be around $10,000. And then the bring up and debug boards, which is going to be one-time cost for checking the chips, is going to be around $5,000. Similarly, for coming over to the packaging and testing, the per chip packaging cost will be around $20 per unit, which is the average industry rate. And then the testing setup, which is going to be one time, so will be $10,000. And bring up and debug boards will be around $5,000. There might be requirement for per unit testing cost, which is additional per unit rate, which is undeterminable right at the moment. So most of these are one-time capital expenditure and can be recovered over product like large volume of production. And the average cost of an ASIC die is going to be around $50 per unit at production at large scale. So other important things for us is going to be our PCB and our heart rate sensors and for the hardware setup you need like power units and then clocks, memories, etc. And also going to be the 3D model, which is going to close and enclose our model. So the bill of materials for these is we need a high quality PC because of the we need requirement for high speed connection required for data throughput. That will be on average for a logic board is going to cost around $5,000. And similarly for a sensor it's going to be around $80 per unit, especially for high medical grade accuracy. And then the power power regulators, clocks, memories, and connectors going to be around $50 per unit, and then the casing is around $25 per unit. So with an total per unit cost to be around, as I said, for ASIC die is going to be around $50, and then for PCB and other components it's going to be $1,000, and for mechanical case it's going to be around $30, and total shipping cost and miscellaneous will be around $10. So total cost we are estimating will be around 1,190, and if we can product, according to our market research, the estimated market price will be from 250 to 300 per unit, which is it's going to be a large gross margin potential at a large scale production level. So other thing we had to take into consideration is going to be the certification compliance for this. So for a medical equipment, you need a lot of compliance and certification. It's going to be a one-time cost, but it's a necessary cost. So we have multiple clearance, like which will be ranking our device based on our risk analysis classification. Considering our device has a pretty low amount of risk, it will be around $75,000 to $200,000 for FTA 510K clearance, and then CE marking is around 50 to 120K, and HIPAA compliance is going to be 10 to $50,000. ISO is going to be 20 to $60,000. Logistics will be around $25,000 on average. And the gross margin model for our model, if we are going to sell per unit at 190 and the market price is 275, the average gross is going to be around $85, and which on a margin will be around 31%. If you're going to sell it for a large scale, at 1,000 scale, amortized values can be around 45 to 50% profit levels. So, yeah, thank you.
Hi, this is Akshaya. So I'll be giving a high-level overview of our system. So what happens in our system is the patient will be monitored like regularly, and there is a doctor assigned to each patient who will be analyzing the patient's medical history, and by continuously monitoring their heart rate, they'll be extracting the possible symptoms, heart symptoms that the patient might have. So with this data, the doctor selects a suitable model on the edge based on the symptoms, and they will deploy it on the like edge. So there will be so the inference will be done on the edge, like with the patient's regular like monitored data. And so this is about the cloud fallback, where if the confidence level of the edge inference is low, then we'll have to depend on the cloud. So what happens is we'll have the edge device, our device, and the streaming data will be sent from the monitor, like the from the patient to the edge device. And then so if the confidence level is low, so we'll be sending it to the cloud to retrain the model and then deploy a new model. So, if the confidence level is low, the data will go to the cloud for inference, and then the AI frameworks in the centers are accessed, and then the trained model is from the cloud is sent to the edge. So the inference is done via the edge. Thank you.
And hello, this is Hobo, and I would just to introduce about the software part for our this project. So for software part, we have the pipeline for processing our data. So from the data, we do the pre-process, 1D classifier output. And during this section, we use 1D this technique to do the pre-processing as a feature extraction. And also we add another classifier after the 1D to do the data process, to do the prediction. And also to fit more to our hardware, we do the CLM, like to feeding our software module to more compatible to do the hardware test. So I made a little bit two animations about that. So you can see, as you can see in this animation, the original waveform is here. So the first step we do is to input the heartbeat. We do the sampling part. We do for each heartbeat, we take the 256 sampling part. So after that, we use the preprocess and we put it into one ECN module so that we can get the features. And after that, we combine our features. We use the max pool and also the average pool to do the preprocessing. And finally, we do the decision, the FC layer. So for feeding our hardware, the original pipeline is a input following with one ECN, a max pool, a one ECN, a max pool, a one ECN, and another max pool. So that it's taking a lot of parameter. You can say like this is 1 to 16, and this is 16 to 32. This is 30 to 64 dimensions. So the whole pipeline is taking this set parameters. So it's too much. After we do the lightweight per pass, it seems like we only need one convolutional layer, one put max pool, one flatten, and following we use FC. So the parameter goes from this to this. It's a smaller, like a smaller 69 times using fewer parameters. So it's more good. And thank you. And hello, this is animation we did for the product, the situation we may have. Okay, just let us to look at it.
Requesting backup. Where's the doctor? Dr. Catherine, do you think I'm on track to pass?
Well, part of it depends on how good your injection technique is.
Keep chill, young heart. My messenger already sent the latest data to the cloud. That's too slow. Don't you see his spirit emerge?
I need immediate entry. There's a patient in danger.
Join the wait list. Perhaps ask your government to increase medical insurance so the poor don't take our resources.
The messenger still doesn't show up. We are about to die.
And thank you for watching this.